All right, so I'm going to stop there, and now I'm going to invite up to the podium back Johan and Alvaro, if you could join us back to the stage, and then Angelo Dagno and Yuling Shi to get their perspectives on cardiovascular disease in the clinic. You've already met Alvaro and Johan. Dr. Shi joins us from Shanghai Skin Disease Hospital in Shanghai, China, where she leads a research program in inflammatory skin diseases. And Dr. Lodano is the head of dermatology program at the CES University of Medellin in Colombia, specializes in clinical and surgical dermatology, has participated in many psoriasis trials. And both Dr. Shi and Lodano are IPC counselors. All right, so welcome. We're happy you're all here. Maybe we could start with Dr. Lodano. So tell us what it's like in your clinical practice. Typical patient is middle-aged and has cardiovascular risk factors. What's the conversation like?
Okay. First, thank you for the invitation. In our clinics, the median age of the patient is 50 years old. And the years of 18 to 20, we realized a study. And we found 958 patients. And the majority have cardiovascular risk. The principal is hypertension in about 65 of the patients. And after the hypertension, the most common was diabetes and obesity. And for that reasons, our principal goals is two educations. And we have a risk group of cardiovascular risk. And we have on all our patients take the pressure, takes the measures of hemoglobins, glycated, takes the measures of cholesterol, of triglycerides, because it's very important to treat it.
Yeah. So it's a very prevalent problem, it sounds like. And do you work with cardiologists also in these managing these patients, or not so much?
No, internal medicine doctors.
Yeah, internal medicine doctors. Yeah.
And we have a nutritionist, and we have sportive, or how do you say, therapies, sport therapies.
Yeah. Okay. And did the patients take this seriously? Like when they hear about psoriasis and cardiovascular risk, do they believe it? Do they not believe it? What do they think?
Okay, I think that is the difficult part, because we have, for example, diet, creences, or habits, bad habits in our patients. But I think that is our principal work or job is to educate it. And I think that with the time, the patient starts to change their behaviors, and understand the importance to care about the diet, to care about the physical exercise, about to change of relators.
Yeah, it's a big opportunity as they get a lot of trust from you as you clear their skin. And then feeling better, maybe they can exercise more. Dr. Shi, so tell us what's like in Shanghai. Obesity maybe not as big a problem, or is it in your psoriasis population?
Yeah, thank you. Thank you for your invitation. So, just you mentioned in Shanghai, so now we are carrying out a big clinical study. It's a real-world study for we call it SPEECH, Shanghai Psoriasis Effectiveness Evaluation Cohort. It's an independent clinical study. It's supported by government. So we get grant from government to take a look at of, I think for the cardiovascular disease and psoriasis, the correlation. So it's a cohort. So now just only 3 years we just going on. But from the preliminary data, we found the result from the 3 years data. We just want to get the risk factor between the psoriasis and the cardiovascular disease. So we found the smoking, the age of onset, and the erythrodermic psoriasis type and the psoriatic ulcer type. It's the independent risk factor for the patients, for the psoriasis patients with the cardiovascular disease. Also, we detect some the systemic inflammation biomarker, such as the you mentioned the CRP and the ESR, and also we detect HYP. As we know, it's the known risk factor of the heart disease. We found this is a positive correlation between the HYC and the psoriasis with cardiovascular disease. So still, this study is ongoing. So we are looking forward to the good the data between the psoriasis and the cardiovascular disease.
That's very exciting work. Looking forward to see what you learn from it. And it's exciting to see how this work has emerged, internationally around the world. And how we're learning a lot, different patient populations, and results are often similar, despite different countries and cultures and what have you. So Johan, in Michigan, you take care of some very complicated patients. You obviously have an enormous amount of knowledge, about how things work in the basic biology. How do you talk to your patients about this? Do you bring up mechanism? What are some of the phrases you use in your clinic that helps your patients understand what's going on?
Oh, that's a good question. I think Michigan, and I think that probably is for most academic and practice. We probably do not do enough of this in terms of kind of bringing it up to our patients, that these associated comorbidities. But we talk about it and kind of importance of diet, weight loss. But we do not do blood pressure measurement, and we do not do any cardiovascular workup, and maybe that's something we need to kind of look at more closely and address. You
could join my study. We'll get you involved.
You should.
Yeah. So, and I'm curious. The findings that you guys had with the genetic instrument predicting coronary disease being cause-related psoriasis, I think was really a paradigm-shifting way of thinking about things. And I think certainly biologically it makes sense that one inflammatory condition, athero, could lead to a higher risk of other inflammatory conditions, psoriasis in this case. As dermatologists, we always think that someone presents with, GA, you got to think about diabetes maybe, or they have alopecia, you got to think about thyroid problems, what have you. When a middle-aged person presents with a nuanced diagnosis of psoriasis, should we be thinking that maybe this has been triggered by evolving atherosclerosis and get them screened, for coronary disease? Or how do you translate what you learned in your Mendelian randomization study to the clinic?
Yeah, the difficulty with that actually is that, we see the signal, the direction of the signal, the association, but it doesn't really help you to kind of identify the specific mechanisms involved and actually and how this kind of happens. And that kind of creates a lot of lack of clarity in terms of what specifically to kind of recommend and how could you potentially intervene in terms of preventing this. We speculate that it could be that the mechanisms is through increased vascular inflammation, and that's increasing influx of immune cells into tissues, including the skin. But the simple answer is that we just don't know yet, and that's a big gap.
Do you think it's age, the relationship is age and sex dependent? Meaning that we know people have HLA-WC6-driven disease often have it start early in life, in the teenage years, for example, where they could have some athero, but probably not clinically significant athero that would be driving it. Do you think this is more of a phenomenon in older folks, so-called type 2 psoriasis, or do you think this relationship is probably across all variants of psoriasis we see?
It's kind of hard to say. It's also hard to say exactly how big that effect is. I think the odds ratio that we had was in the range of 1.10 to 1.14. Which is a measurable effect, but it's still a fairly modest effect. And there's a lot of other things that kind of can contribute to psoriasis. So I don't think every psoriasis out there has to have a vascular contribution to their disease, but probably a subset of them certainly does. And how that affects and works across the lifespan, I think, again, would make a lot of sense why you would do that, but we just don't know. Yeah.
So I think this was exciting about this field is that I showed you earlier we have over 4,200 publications, and there's a lot of fundamental questions we don't know the answer to yet, which is a lot of good opportunity to help patients drive our science forward, I think.
Yeah, I think we're getting a lot closer to understanding exactly how these things work. And nowadays we have the tools to do it and take it all the way. But it's intensive and costly experiments to do and requires a huge number of patients.
That's right, yeah. So we're going to give Alvaro a chance to respond in a minute, but I want to open up for questions before we're going to break. I know, Andy, I think you raised your hand. There's a microphone over there if you want to come.
Yes, a quick question for you.
Yeah. Oh, okay.
In all of your studies,
Yeah.
you looked at what you just asked him, type 1, quote, psoriasis versus type 2 heart disease, or CW6 in your studies.
Right.
Have you tried that?
You know, it's an interesting question. I think that we know from the earlier work that Johan showed that there's this effect modification by age, meaning that you see the highest relative risks, or we call accelerated risks, in younger individuals. So that would suggest that this phenomenon goes across all age groups in people with psoriasis. But it's not an easy thing to tease out by subgroups because you're talking about statistically uncommon events to begin with, and so it's sort of hard to dive deeper into that. Jonathan.
This question, it's a point for Johan yourself, really. Just to say, we've done the same kinds of studies that Johan was reporting using Mendelian randomization to look at the direction of causality. In essence, we confirmed the findings from Ann Arbor that the major causal direction is from coronary artery disease to psoriasis. And we also see it with stroke as well, so another atherosclerotic disease. However, there is bidirectionality, and we've also seen a stronger signal from psoriasis to cardiovascular disease. And I wonder, we're just doing some more work at the moment, but I wonder if that explains the major finding in your 2006 paper, Joel, that the main risk appeared to be in the young people who had very severe psoriasis. That's where the risk was greater. I don't know what you want to say about that. But the other thing I was just going to say is that we heard earlier on about how important the psychosocial aspects of psoriasis are, and that therefore there's probably a need to recognize it very early. So the question is, you're doing a study and you're looking at cardiovascular disease and psoriasis, and you're telling or you're informing patients of their risk of cardiovascular, those who've got psoriasis, their risk of cardiovascular disease. Are we getting the cardiologists to tell their patients that they're at risk of getting psoriasis?
So that probably not. But I think the first part is really how much of the guidelines disseminated out to the broader field of medicine and cardiology. You know, it's highly variable in my own experience. Some people are like, of course, psoriasis patients have higher rates of heart disease, or I had no idea people with psoriasis have higher rate of heart disease. And us as a specialist managing this disease, our obligation is to make sure our patients will see other clinicians who understand what's going on. Like the last thing you want to happen is you refer your patient to someone for evaluation of heart disease, and they're like, I had no idea psoriasis is associated with heart disease. That's not a good experience for the patient. But it's pretty well accepted, obviously, according to the guidelines. I think to come back to the issue of the GWAS work, it's important people recognize that one is the issue of pleiotropy. You know, you're trying to take out genes that affect more than just the skin that could affect cardiovascular disease. That's not how patients act, right? They get their genes, and it makes them a risk of psoriasis, and we can't just exclude the ones that seem to have a direct relationship to vascular disease. They're also psoriasis risk factors too. And the genetic instruments are pretty weak for who's going to develop psoriasis, right? So most people in those studies don't even have psoriasis, and that creates some issues with interpretation, I think. Hervé.
Yeah, congratulations to all, and very, very insightful. And to rebound on Jonathan's question, specifically to Johan's reference to the Patrick paper in Nature Communication with the trans disease meta-analysis of the genetic loci. The facts that you identify among those, IFIH1, as you showed, for which there is a single gene model with a syndrome, the Singleton-Merten syndrome, where there is psoriasis and there is also cardiovascular atherosclerosis, which is accelerated. And there is also the sensitivity to viral triggers as an accelerator. So do you, and if we move aside from one is preceding the other, one is fueling the other. Do you envisage that in some cases we have to deal with a stratification of patients for which, in one case, IL-23 inflammation-promoting genes, in the case of IFIH1, type 1 interferon-driven inflammation, should be dealt with in a different and stratified manner with targeted therapies, and it's not one drug on one size fits all. Aside for, of course, for the behavioral changes and the diet and so forth. And this,
so Hervé, this is a perfect question for Alvaro Gonzalez-Quintero. So Alvaro, could you answer this question for Hervé?
Well, so personalizing the treatment in accordance to comorbidities, and so for me, all the things that we are hearing here make it complicated to act in a daily practice, because we need to consider so many things. So first, like the question was to personalized, and
it's no, well, yes and no, and it's I know that we are not yet there, but do you envisage that based on other disease where there are some single gene models which are much more prevalent than we expect, right? I mean, for TB, for SARS-CoV-2 infection, and so forth, and so on. So with the Patrick and Alexoi paper in hand, do you envisage that there would be some type 1 interferon-driven cases of both psoriasis and atherosclerosis, driven by the same genetic abnormality, right? Whatever is the sequence. That's, and of course, that the approach, the targeted approach, would be different depending on the gene in question. That's my provocative question.
I'll give Alvaro a phone a friend response. I think that cardiovascular disease is so complicated that it's seldom one factor alone driving the event, right? So invariably, if you are in a situation where you could figure out, okay, this is the pathway, it's active, we should really hit them with this immunological drug, they still have other issues that are driving cardiovascular risk that relate to celiac disease, would be lifestyle or other issues going on that would need to be addressed.
Of course, but in this case, it showed some data which were convincing. That's why I'm.
No, I think you're right. We already know that that's the case from like the pustular psoriasis, where you have one, like IL-36 receptor antagonist mutations and driving GPP. I think we'll see the same thing in plaque psoriasis, that there will be these very narrow specific pathways, such as the double-stranded RNA sensing or these auto-inflammatory or interferonopathy type mechanism could drive part of the disease. But I think if you think about psoriasis as a whole, we know now of like 170 different genetic variants that predispose to the disease. And each one of our patients are going to be a composite of those variants.
Right.
I think, yes, we will probably be able to stratify it. HLA-CW6, we can do that to some extent. But it's going to be complicated and it's going to be inaccurate, and I think we need something more than just the genetics to be able to do it.
Yeah. Sure. So we'll close the session now and say, first of all, thank you for my panelists and sharing your expertise. I learned a lot from all of you. And I think we've learned a lot. We have a lot more to learn. But while we're figuring it out, we have a big opportunity for at least educating patients, screening for risk factors, helping them get managed per guidelines.
Dr. Geffen,
Yeah.
I have a question.
Yeah.
Do you consider that we should offer our patients colchicine?
Colchicine, yeah. So colchicine is for the advanced patient. So those who are pretty high risk or they have known coronary disease, they get a coronary calcium score back that's high. Those patients often will consider it, and usually I'm deferring that to the prevention cardiologist for those discussions. But there's about 3 or 4 clinical trials now proving that it's better than placebo, so it's pretty impressive.